We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ACHIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research. Hey, Nikki, it's nice to hear you again.
You too, Jess.
So tell me, what's new in your world?
Okay, so nothing is new. It's still been the same old COVID mix. What about you?
Same old.
Yeah.
So I have a joke to brighten your day. Are you ready?
Okay, I am.
What do you get the person who has everything?
What?
Penicillin.
So silly.
I know.
Thank you for that. That's cute.
So now that we've had a little chuckle, let's kick things off today. Today we're going to be speaking with the authors of the article PPE Training and the Effectiveness of Universal Masking in Preventing Exposures, the Importance of the Relationship Between Anesthesia and Infection Prevention. And I think we all know after the last 18 months how important those relationships are. So with us today to talk about their article are Jill Holdworth and Dr. Jay Sanford. Jill is the current manager of infection prevention at Emory University Hospital Midtown in Atlanta. She began her career as a cardiac rehab therapist. Jill began working as an infection preventionist in 2009 and became a fellow of APIC in 2016. She has served as the chair of the Emergency Preparedness Committee and in several chapter leadership roles. Jill is also an EMT, is certified in sterile processing through IPC-Anesthesia, and serves as a co-chair of the AAMIC Protective Barriers Committee. Welcome, Jill. We're so pleased that you were able to join us today.
Thank you so much. Happy to be here.
Awesome. Also with us today, we have Dr. Sanford. Dr. Sanford currently serves as the chief of the Division of Perioperative Medicine within the Department of Anesthesiology in the Emory University School of Medicine. He also serves as the residency site director at the Midtown campus, is co-chair of the residency's Clinical Competency Committee, and is the current EROS liaison for the department in that location. Dr. Sanford is also actively involved in departmental quality initiatives, research, and implementation. Thank you so much, Dr. Sanford, for taking the time to join us today.
Thank you for having me.
So to kick us off, Dr. Sanford, I was hoping that you could give us a little background on the situation that occurred that prompted this article.
As we all know, COVID was raging about maybe 16 months ago. I think it was April. And we had one or two of our either anesthetists or attendings complain of symptoms, go off and get tested, and then come back positive. And Jill and I kind of met, and we thought, I wonder how many people were exposed to this individual. And then we just went back through the areas that they were in, where they ate, where they sat, who they interacted with, and it was pretty clear that they had been all over the Department of Anesthesia and the hospital at that point. So it was sort of, at that point, we decided it was best to try to come up with a strategy to either test or question all the people that had come in contact with these individuals.
Yeah, that sounds like it could be pretty intense, pretty fast. So, Jill, it sounds like, based on what I was reading in the article, that infection prevention assistance was welcomed by the anesthesia department, although there had been little interaction between the departments prior to COVID. Was there any reluctance from anesthesia to work with infection prevention at the time?
Yeah, so this relationship has been an interesting one. And I would say before COVID, there wasn't a whole lot of interaction between IP and anesthesia. And it's like a lot of departments, the kind of view of infection prevention when we come towards them. Some people don't know what to think of us. What are they coming to audit? What are they coming to look at? Are they going to tell me to wash my hands or that I'm doing something wrong? And I would say anesthesia probably generally thought the same thing too. If we're coming into the OR to watch a case, we're generally probably watching something or auditing something. So this wasn't really a relationship that had been well formed yet before COVID. And there was a lot of hesitancy to put a lot of trust in IP and to have that, really great relationship where they came to us with things. And when COVID hit, it kind of all shifted. And I think we saw that in infection prevention with a lot of departments, which was kind of one of the silver linings with COVID, that people started to lean on us. They started to come to us with questions, and they put a lot more trust in us because they almost had to. So this was one of the departments that completely shifted as far as what the relationship used to be versus what it is now. And I can say that it's been such a welcome change. The anesthesia department has been such great partners. They've been assets now and more things than just COVID, but they have been partners in SSI prevention and investigations to where we didn't have such a strong relationship before. And it really stemmed from, in the beginning, everybody was scared and they had a lot of questions, and we were the ones that they really needed to come to. And so we formed that kind of bond and trust really early on, and that really helped solidify our relationship. And it wasn't just this particular incident that happened with it. It was just COVID in general. And then when this situation happened, we already had that relationship started. And when Jay says we had to look at who all was potentially exposed, and a lot of it was what he said was, break rooms and eating, and which a lot of exposures, I know all the IPs can concur that a lot of exposures happen during break times and eating. So this was a large exposure because of that, because a lot of the anesthesia staff break at the same time and they break together because this is a close-knit group. So this exposure was large, and everybody was very nervous and very scared about what had happened and that they were exposed, because this was very early on in the pandemic. So because we had already built that relationship and built that trust, that helped with the situation too, because everybody became more scared and more nervous. And so they were able to talk to IP, ask their questions, and they already trusted us to help them through this situation. And so that was just kind of the icing on the cake with something so scary like this to happen, when basically your entire department almost was exposed and had to be tested in a very short period of time.
Jill, I think that's so lucky for you all that the relationship changed for the better between infection prevention and staff, because we talk in a prior episode about the relationship between infection prevention and staff during COVID for rural communities, rural hospitals, and not everybody was so lucky to have such an open-minded staff, an open and welcoming staff. So that's great to hear. And I'm interested in what's the structure of your infection prevention team at the hospital?
Yeah, sure. So I'm the manager, and I currently have 4 IP coordinators, and we have one open position. So we would technically have 5. And how we structure ourselves is we designate an IP for every department or unit, every specific area. So every area has a designated IP that they know that they can go to at any moment in time. So every unit has their designated IP. And we also made sure every department had a designated IP, which before COVID, we had done a pretty good job with that, but we didn't have every single department, like spiritual health, the greeters, patient experience. We didn't have every single department as well covered as we had all of the clinical units. So this was a chance for us to make sure every single department in this hospital knew who their IP was and were assigned an IP if they didn't already have one. And anesthesia was one of those departments. So we made sure anesthesia had an IP, they knew who their IP was, and they knew who to contact. And that IP ended up being me. Even as a manager, I have a lot of departments that I cover myself. And this was such a welcome change from what I saw to anesthesia. My contact information ended up on their personal webpage. Everybody knew how to get a hold of me, and they still do, even a year and a half later. And I think they just appreciated that they had somebody to go to, they had a resource, and that they weren't left out there alone. I've noticed even still that sometimes anesthesia gets left out. The OR is a big place, and sometimes communication gets sent to the OR, but maybe anesthesia is left out. So really making sure that somebody had anesthesia's back, and that they were always going to get communication about PPE or masks or something going on with COVID. There was somebody that made sure anesthesia also got that same attention and same communication. And that's how we treated every department in the hospital. And with an IP covering every single place in the hospital, we were able to make sure that communication reached everyone. And we spent a lot of time in the hospital with the teams. We were here every day. We never got to work from home because we felt like it was more important that we spent time with the team members and with the doctors and staff, because that's what they needed during this time of crisis. They needed somebody's face to see and to ask their questions to their face, not just to see an email. And I think that is how we built these relationships stronger, and that we came out for the better in the end of it. And everybody got a better relationship with infection prevention here because we put that time in and made sure that every day we showed our faces on our units and in these departments.
And how did that change your relationship with administration as well? Did they I don't know what the relationship was like before, but was there an increased sense of importance for IP being at the table and being able to lead?
Yeah, no, that's a great question. We're lucky here that we have a great administration who's always been really supportive of infection prevention. But I do think that it gave a much better sense of all of the things that we do, how important that we are on the floors and in the departments, and how visible we are, how critical we are to certain decisions, and just really how hard we work and how much that we do and how much people are going to rely on us for certain things, how much training that we were doing. It really put us in the spotlight. And I know a lot of IPs feel that way around the country, around the globe, really, that if you didn't know what IP did before the pandemic, then surely you do know what they do now and how important they are and how much that you can rely on IP for so many things. And I think that it's really put a spotlight on IP and how much we do. It's more than just telling people to wash their hands or reporting at meetings. There's so much that we do all over the place in these hospitals and in our facilities. So our executive team and leadership was always supportive, but I do think that it just really showed them even more what we do and how much that we can benefit this facility.
And I'm wondering, too, if you can talk a little bit, and Dr. Sanford, pipe in here, too, if you want, the sense of urgency that you all must have felt, because that entire intervention of getting everybody tested and doing all the contact tracing, that has to go quickly, right? You did, 109 employees over 3 days?
Yeah, I mean, I think we did the majority of those, too, in the first maybe 8 or 9 hours. It was a pretty robust endeavor. But I think at that point we'd established the connection between our department and Jill's department and how valuable they were in keeping us safe. Just kind of going back to what Jill said, just to add, I think not only did we know they had our back, but we also knew that they had the information and they had the equipment and they had the resources to help keep us safe, which I think gave a lot of people apprehension. Running off to intubate a COVID patient when we didn't have vaccines and we didn't know what the long-term sequelae were going to be of this disease. It was pretty nerve-wracking, but when we were able to establish that relationship, I think it put a lot of people's mind at ease. I know it did for me, especially, I could tell my wife that, hey, we're safe. I've got the PPE I need. I've talked with Jill today. She's going to make sure we have this and that. So it was a real lifesaver in that respect. And I think because of that, when we said to everybody, like, hey, look, a few people have COVID, they were here, they had symptoms, they weren't masked. We'd like to test everyone, can you come down? I mean, the line was out the door within, 20 minutes.
Well, great job, guys. Great mitigation. Great job.
So that's, I think it wasn't difficult. It was difficult in the sense that it was a lot, but it wasn't difficult to convince people to come get the test.
Mm-hmm.
Jill, I don't know if you want to add to that. Yeah.
It's amazing that you only had, out of the 109 tested, you didn't have any additional staff testing positive after the first two, which seems almost impossible after the close contact, and that interconnectivity that you talked about amongst the group. What do you think were the most significant factors in preventing the seroconversions in these folks?
Masks, social distancing. I mean, that's all we were doing at that point.
Was the social distancing a little more evident after you discovered that everybody was eating in the break room?
Yeah, and it's important to remember this was very early on in the pandemic, whereas we put a lot more emphasis on social distancing and certain things a little bit later. This was, just a month or two after universal masking went into place. So it's hard to even remember that far back in the pandemic with everything that's gone on. But the important thing I think that we did was we made sure that everybody had PPE training. We made everybody go through a donning and doffing training, return demonstration. We made sure everybody was comfortable with whatever PPE we had, that they knew how to don and doff correctly without cross-contaminating. We really worked hard with people on the N95s and taking them on and off. We made sure people felt really comfortable, because there was hardly anything that actually felt comfortable at that period in time, because this was all new back then in spring of 2020. And we worked very hard with people to do things right. And I think the amount of time we spent training and making sure that people distance as much as possible when they were eating and breaking, and especially when they were in the OR. A lot of these folks were in the OR all the time. And I think that was to our benefit, because they wore the PPE and they wore it correctly when they were providing clinical care. If they were doing ICU airways, they were wearing the PPE we asked them to, and they wore it correctly. And I think that all the training that we did and all the questions we answered, making sure that they were doing it right, and all the hand hygiene that they were doing and doing it right, I think that really helped us to make sure that we didn't have any additional positives. And we were also really focusing messaging in this healthcare system on making sure that you were doing everything that you could outside of work too, to prevent exposures and to keep yourself healthy and your family healthy. And so I think those kinds of messages too really helped to make sure that we were keeping ourselves healthy at work and outside of work.
Do you think that also this particular situation contributed to increasing compliance with those things for the long term? So even now, are you still seeing that the staff are maintaining this high level of compliance with hand hygiene and the masking and physical distancing?
It's probably waned, but I mean, it's done that across the country. We're down here in Georgia, where I think, the pandemic has existed for everyone, but only for some people. And if you understand what I'm saying. And I think that, I think people are we're a little tired of it. So we got a little bit lax, and then Delta came along and sort of changed the game a little bit. And I think that's gotten people's attention, because we have had more positives in the last probably 2 months than we've had the entire pandemic, really. So I think people are getting back to it, but there was a pretty good lull there for a while of people just sort of throwing caution to the wind again and thinking we were through the worst of it. But I think now they're going back to masks, hygiene, being careful, watching what they do outside the hospital, that sort of thing. Would you agree, Jill?
Yeah, and I would refer to it as PPE fatigue. I think when the numbers got briefly better for a few weeks, everybody was going to their PPE fatigue, and they didn't want to keep wearing all of the PPE again, and they were laxing on their eyewear, and they weren't being as careful anymore. And I think everybody got optimistic for a very brief period of time right before the Delta numbers spiked again. And I think that we wanted to be optimistic, and we wanted to think that this might finally be getting better for good. And unfortunately, I think people are just getting tired, and we see it everywhere. Everybody's saying that that their healthcare workers are just fatigued with wearing all of the PPE. And I think that we can all relate, but we have to keep reminding people that this is what we have to do to stay safe. And I think that it also goes to when we had the vaccine available, everybody thought this is what I need to do to keep myself safe. And they got the vaccine, and now we still have to keep our PPE on just as much as we ever did because not enough people got the vaccine. So now it's really tiring for the healthcare workers who have been doing this for so long. And I think that what Jay said is absolutely right. Everybody just got a little lax because they got tired. And then when Delta came, it kind of whipped us back into shape to say, we really have to wear our eyewear every time that we have to. We have to make sure that we're wearing the N95s when we're supposed to, if that's your policy. So yeah, it's been hard, and it's also hard to continue socially distancing when you're eating and when you're in the break rooms. If you think about how far 6 feet really is, and we know that that's hard for people when all you want to do is to be able to interact and to socialize with your coworkers, and sometimes there isn't even room for two people in these break rooms, and all we want is to have a little bit of downtime and socialization, and sometimes we can't do that. But with this group, I will say they have done a good job at trying to minimize how many people are in the break room, even when it got a little bit lax. All it takes is just some reminders. With some people that have tested positive in the last few months, it's given a good reminder that we have to continue social distancing in the break rooms. I know that's one of the things that IPs across the country have struggled with over the last few months. So it just continues. And I know it's also because everyone just wants to take an actual break and have actual socialization time. So that's been really
Sure. It's the one bit of mental
Right.
break you get during the day. It's been very hard. Yeah. Yeah. Understand. You just bring them pizza. All the healthcare workers love pizza and donuts.
Well, and that's the hard part too. When people bring in things, they want to donate food, they want to have a pizza
Yeah.
party. Can you really do that? Is that contradicting the things that we're telling them? Like, let's do a pizza party, but you can actually eat together. You have, you take your
Right.
piece of pizza and run because you can't eat with your friends at the party. But here's some pizza.
You can nod at each other on the way
Yeah.
out, right?
Yeah, I would also add that I think here at Emory we've really benefited from the fact that, our CMO at Midtown is an ID doc, and he's fantastic. And he was, as soon as we had this outbreak, he was on top of it too. And then, we've got like Dr. Varkey in the system and Dr. Sexton in the system, and they're awesome. So, and we've got the CDC in our backyard. So I really do think Emory is kind of a shining star in that respect. And I think our in-hospital transmission is exceedingly low. People got it in break rooms, but nowhere else. Even patient to provider contact is, at this point, it's nil transmission. So it's been great.
One other question that I would ask is, because this is something that our team in particular has been looking at, is what the long-term policy changes may be as a result of COVID. So down the road, hopefully, some of the things will go back to a new normal. But are there things that you're looking at around infection prevention policies, maybe around masking, eye protection, or things like that, that you are planning to make some changes, some permanent changes for the future as a result of what we've been through with COVID?
Yeah, we've discussed some things, and then we changed them. We were discussing certain policy changes before Delta, and then when Delta came, we kind of went back to 100% COVID policies. So I can't say for sure what will be changed. I know across the U.S. some discussions have been masking during respiratory season, and does that make sense? And a lot of folks are thinking, yes, it does make sense, because it seemed to eradicate flu season last year because we were masking in healthcare. So does that make sense So I know that's one thing, up for discussion. And should we be wearing eyewear more often for our respiratory patients? And so I know there's a lot being discussed in the ID and IP world about permanent policy changes. I don't know that anybody's really ready to make any of those changes quite yet, but I think that we have seen that some of these PPE policies we've used in COVID could potentially be used for respiratory viruses in general.
Yeah, those are two of the things that we've actually been talking a lot about. So I'm glad we're not the only ones kind of going down.
Right.
Well, what would you say your biggest takeaway? I want to talk to both Jill and Dr. Sanford. What's your biggest takeaway from these readings for our listeners?
PPE works in cooperation is part and parcel with the whole process. It can't be done without cooperation between IP and anesthesia or IP and any group. And then when it does work, when the communication is there and you have the right equipment and you use it correctly, you can save, you save infections and essentially save lives. So I think that's the takeaway from my point of view.
All right. Thank you.
Yeah. And I'll say one of my biggest takeaways is that, one, the IP department being visible, that is your biggest asset, being in the units, in the department, spending one-on-one time, being with these team members, especially in a time like this in crisis. That was what worked best for us throughout the entire hospital. So I would say to do that all of the time, not just during crisis, but that's one of our goals as a department, is to be seen, be visible, and be available for people to ask questions. And you quickly become part of the family and part of the team with these units and departments. And that's really where you want to be. You don't want to be viewed as somebody that's scary or the auditor. You want to be viewed as someone who's approachable and really be invited as part of the team. And I truly feel like with this group, I became part of the team, and that's what kind of led us to where we are. And like I said, this was a kind of a strained relationship before. I would say, scared to present to this group and in front of this group before COVID. And that quickly went away as soon as COVID started, and we got to a much better place. So I would encourage everybody to get to a place like this with departments and just spend time with departments until you get to this point in a relationship with these departments where you can trust each other. But it does take a lot of work, and it took a couple years here in this facility for our department to make those relationships with all of our units and departments.
I think that's great advice.
Yeah, it's so good. There are some positive things that have come out of the pandemic. And I also appreciated the fact that you mentioned that building such strong relationships with this group also, got you better assistance with SSI prevention and other initiatives in infection prevention, because we're always looking for additional assistance from those stakeholders that are involved in these areas. So I think that's fantastic as well.
Yes, absolutely. And it's amazing the different perspectives that some of these departments have. And anesthesia has a much different perspective on SSIs than other people in the OR. So if you don't have anesthesia as part of your SSI team, then that's really something you're missing out on. And Jay is our physician lead for our SSI team. So that's how important that we feel anesthesia is to SSI prevention. So that's something that everybody should look into if they don't have that anesthesia support.
Plus, we're really nice people.
They are. I do agree.
Usually.
Well, that's great to hear. Yeah. I enjoy listening to the collaboration and the camaraderie that you guys have together. So on that note, we will wrap it up. I just want to thank you guys very much for giving us your time today and being with us. I think that was a very helpful conversation.
Thank you.
All right, Nikki, are you ready to talk with our next guest for today?
I sure am.
All right. So today we have with us Dr. Chetan Janadatha. He received his MD from JJM Medical College in India and his master's in public health from the School of Public Health in Texas A&M Health Science Center in Bryan, Texas. He completed his internship, residency, and fellowship in infectious diseases at Scott and White Memorial Hospital in Temple, Texas. Dr. Jinadatha currently is the Chief of Infectious Diseases section at Central Texas Veterans Healthcare System in Temple, Texas. He is also a clinical associate professor of medicine at Texas A&M Health Science Center in Bryan, Texas. He has extensive experience in prevention of healthcare-acquired infections. His clinical research interests focus on the role of surfaces and causation of HAIs and how technology might be able to solve the problem of HAIs as well as Legionella and COVID prevention. Dr. Jinadatha has also testified as an expert witness in the use of technology for prevention of HAI in front of Science, Technology, and Space Committee of U.S. Congress in June of 2014 and participated in several task force related to Legionella prevention in the VA, as well as wastewater surveillance for COVID. Dr. Jinadatha has also authored several chapters in the APIC textbook of infection prevention and control and has published several manuscripts in peer-reviewed journals. Welcome, Dr. Jinadatha. Thank you so much for coming today.
Thank you so much for the invitation and the kind introduction.
No problem. So today we are talking about capturing portable medical equipment disinfection data via an automated novel disinfection tracking system. So when Nikki and I were reading about this, we were both very intrigued about this system. So can you start us off by just telling us what prompted this research in your organization?
Absolutely. Disinfection, especially disinfection of surfaces, has been a hot topic for the last several years. We have seen the evolution of UV technology, hydrogen peroxide, copper, and various other technologies that help us keep the environment around the patient clean. During the same approach, we have noticed that portable medical equipment, such as the computer on wheels, people call them cows, or workstation on wheels, or WOWs, and then there are IV poles, several other equipment move in between patient rooms. And what we noticed that they are also healthcare surfaces, and they are probably infrequently cleaned more than we imagine. And the tracking system for such disinfection was lacking. And ever since I have been in this institution, as well as before during my training, I noticed that they're what are called orphan items, or items that are forgotten. And I've always wondered there's got to be a better way to track and disinfect them and kind of ease the part where people have to remember how they cleaned or when they cleaned it. So during this process, we started out monitoring the equipment and noted that there was a lack of proper tracking. And whenever Joint Commission came, many hospitals, including ours, get into question, when did you clean? How do you prove that it was cleaned? And that prompted this whole research in terms of this portable medical equipment, also known as reusable medical equipment or non-critical medical equipment. So many names, but they all represent the same group of equipment that surround all our patients in the room.
What is the size of the actual DTS, the disinfection tracking system? And the reason that I'm asking is because it's such an inventive, neat tool that I'm hoping maybe in the future there's technology where there are smaller sensors that can go on to some of those smaller items we talked about, stethoscopes or what have you, whatever you're transporting from room to room that might not be as big as a WOW or a BMW or whatever you call those, whatever the hospital calls it.
Absolutely. So I will clarify that for those who have a hard time seeing the picture on the article, I would equate that to the size of an iPhone. To answer your question even more in detail, the technology that is in the size of this iPhone can be integrated into the surface of the equipment if a manufacturer wishes so. So it's pretty unique. What needs to be supported is the capturing mechanism of the disinfection and the system that transmits the information captured here to an online portal, so people can track it in a remote fashion, not have to check the screen. So the screen also has a display for the user. So that can also be integrated into an equipment. So if you put it as an add-on device for an existing equipment, it is the size of an iPhone. But hopefully one day this becomes part of the equipment itself and nothing needs to be attached to it. So, more comprehensive solution, if I may say so.
Yeah.
So one of the interesting things that I noted in the study was that it said the device can be set to record moisture events with a duration appropriate for the wipe being used. And as we know, there are a variety of different wipes out there with a variety of different wet or contact times. So this is really cool technology. Can you tell me, were there any determinations made from this data specifically?
Absolutely. So not only can it detect moisture, I don't know if I made it clear in my article, it also can detect UV light also. And since it is a sensor, the threshold of the sensor that detects either the moisture or the UV can be set to meet the specifications of the end user. For example, if you're using a wipe that has a 1 minute contact time, you can set it to where it has to detect moisture for a minute before the sensor condition is fulfilled, and then only will it change the display from 4 hours to 0 hours or dirty to clean, and the language on that display screen also can be changed to whatever. We chose 0 hours because we didn't want people to feel like their dirty equipment is being used during the study, so we chose hours since the last disinfection as a method. So to change that display, the sensor needs to detect moisture. In this study, since it was in a beta phase and we were testing it out under IRB protocol, we wanted to find a balance where the end users were not frustrated that the signal was not changing, although they have done the disinfection. So we set it for 10 seconds, but it can be easily set to 1 minute or 3 minutes, anything that the end user wants.
Cool.
And I think something else that's cool about refining this technology, one of the limitations you put in the article is basically an employee can wash the DTS, but not wipe down the rest of the equipment and kind of bypass that mechanism, right? So unless we're doing periodic visual observations to make sure they're actually doing this, that can be problematic. One thing I think that's so cool about being able to refine the technology and put it into the equipment and onto the equipment is you can't really get around that. I mean, unless it's obvious where the sensor is and you just scrub that little area for 10 seconds or however long it needs to be. So I think this is really exciting technology that's coming up. So thank you for doing that work. That's awesome.
Thank you. And you correctly pointed out the limitation. But here is what I told my team and some of the skeptics when we were putting this in, like, how do we know that the end user won't be just using it? I said, most of us are in the healthcare sector because we want to do the right thing for our patients.
True.
Our nurses are excellent. They all want to do the right job, and we want to aid them to do the right job. This technology, at least in this design, is not designed to catch cheaters. It is to help people do their job.
Yes.
So I have utmost confidence that whoever wishes to adapt it will use it to be a better aid to do their job easily than to trick the system. We have built in a couple of cool features to be able to catch the cheaters, if I may say so. It has a motion sensor also built in. So if you are wiping a cow, you do move the cow or the wow enough to detect motion. So we can also see if they're just wiping it, but we didn't refine it. And again, our goal was mainly to aid and help people who want to do the right thing. And I think we achieved the goal with this study.
Yeah.
So I think that especially during this time with COVID, there is an increased sense in staff wanting the equipment to be that much more clean and disinfected, especially between shifts and patient turnover. Would you say that the staff, the timing of the cleaning and disinfection sort of spoke to staff cleaning in between their own uses of the equipment?
Absolutely. I think what COVID did for the healthcare industry is exposed us to a lot of stress and a lot of things to do in a very limited time with no breaks for the staff. And we started doing this before we even knew COVID existed. And so when COVID happened, I think what it did is, okay, I don't have to remember when I wiped down the equipment. It says on there 8 hours ago. So, or 10 hours ago, whatever your policy is, you just have to match your policy with the cleaning. And so one cool thing, even before COVID, we noticed in the studies that at night, when the nursing staff had a little more time, we saw a lot of increase in cleaning. They saw that it was 16 hours since last disinfected. Why not wipe it down? And that goes to show what I mentioned before, that nurses and doctors and healthcare workers want to do the right thing, and just helping them not have to worry about when I last disinfected did increase the disinfection activity, especially at night. So proving our worth. And I think that's the same analogy I would use for COVID. When we are busy with a million things going on, the last thing you want to remember is when did I do what? And all equipment look the same. So it's hard to keep track of them unless you want to remember the EE code on the equipment, barcode on there. So this was another way to look at and just not have to worry about various things that are going on around you.
That's a really great point.
I think having the DTS, the system, actually attached to whatever portable medical equipment you have rolling around will serve as a reminder to clean when sometimes you forget to do that disinfection. So you talked about the Hawthorne effect in the paper, and I think that this might kind of have a Hawthorne effect, but in a good way. I don't know if that makes sense or if I can apply the Hawthorne effect to that, but it's a reminder to disinfect your surroundings.
Absolutely. And one thing that's not mentioned in this paper, but we do have another study that is under review related to this technology. In that study, we actually implemented the DTS without the feedback and DTS with the feedback. And what we noticed is that the people who had the feedback were cleaning more than the people who didn't have the visual feedback. And when we turned on the feedback in the same unit, their cleaning rates also went up, which again goes to prove that people want to do the right thing if they have the right technology to aid them.
I have another question that is a bit of a pivot, but you said you're an expert witness, or Jesse mentioned you'd been an expert witness before. And I know that some of the, how there are hand hygiene systems that can sense the the alcohol. There's a sensor on your tag. And so something will kind of yell at the healthcare worker if they walk into a room and don't disinfect their hands within a certain amount of time. I wonder, I've heard of hospitals being able to use that in litigious situations to show that they have been performing hand hygiene, where if a hospital has been under question for spreading hospital-acquired infections. And this can also kind of be used, I think, to maybe prove that they are following their hospital policies and doing their cleaning, and that the hospital-acquired infection probably didn't come from the medical equipment or the healthcare worker. Do you see any benefit in that?
Absolutely. So one clarification, when I'm an expert witness, I'm not a witness that participate in litigation. I was labeled the expert witness for the testimony I did in front of U.S. Congress. So on behalf of the VA, okay. I digress. But answering your question, you are absolutely right. When I thought of this technology, and just for disclaimer, I am the inventor of this technology, and the technology belongs to the VA, and now it is licensed by a private company from the VA to develop this. One of the goals I had was, if Joint Commission or another agency, we as in the VA get reviewed by several agencies, they all ask the same line of questions. How do we know you do your job daily? Short of me keeping a log of every single equipment, when it was cleaned by whom, we had no other way to track it. So one of the reasons we developed the tracking system where it captures the disinfection and logs it in an online portal was when when by my mistake the catch is not doing a disinfection, we don't want that one event to overshadow the entire certification process or review process. So then we can produce an automated log worth years worth of disinfection and show that that was a one-off event versus a repeated pattern, which is what Joint Commission looks for. So I didn't think of litigation. I was thinking more of hospital accreditation when we developed this. And I think that tool can definitely help us during accreditation review visits.
Yeah, because there's a neat little graph or chart, or I don't know what you would call this, but it's a screenshot or something of the number of recorded cleans by the portable medical equipment. So you can pull how many times this specific item has been cleaned and when. And I think that is really, really neat. So,
yeah, I think that's great too, because I can say from my own experience with Joint Commission, when you can show them beautiful tables, charts, what have you, with the excellent work that you have accomplished using some form of, automated tracking system, they really appreciate that. And I think it helps them, as you mentioned, be able to better visualize that you have these trends of good cleaning process or good hand hygiene rather than, those one-offs that, maybe somebody's out on the floor and they do a direct observation and they see one person not do hand hygiene or one person not cleaning the equipment effectively. Whereas then you can actually show that that is just what it is. It's a one-off situation. So that's fantastic. I'm wondering, though, how the staff perceived the study and if they were presented with the data after the study was completed.
Absolutely. So we did this with full disclosure because we didn't believe in secretly introducing it. We did train them to include the device when they're doing cleaning, just so we capture both the cleaning and the cleaning of the equipment. We didn't want them to leave it out and not get the credit for cleaning. So we did a little bit of pre-implementation education on the floors that we implemented it. And after the study was done, my colleague, Dr. Williams, who is an RN, PhD RN, did a formal focus group and surveys. And we actually have been accepted. The results of that publication have also been accepted. It's not online yet. And there was excellent feedback from the nursing. Some of the concerns about, how do we know if they just disinfect the equipment itself, which is an obvious flaw we know of, was also pointed out. They also talked about how they were able to demonstrate that they actually clean, meaning they actually like the fact that we gave them credit for all their hard work. Many a times, you do all the hard work and you don't get the credit, and they felt that this was a way to validate. And what we noticed is that 8 o'clock in the morning, before the shift started, all the nurses cleaned all the equipment they were handling. And it was perfectly visible in our pattern. And we showed that. They were very excited about it because it was like, we told you guys we do our job. And this is a way to prove that.
Maybe I'll get this for my house so I can give my boys some credit when they clean.
Absolutely. And there is usage probably in food sector where the surfaces in the food industry need to be cleaned. I talked about bathrooms in airports where they have manual logs. This could be another place. There are many uses for it, but mainly we developed it for the hospital. And I think the nursing staff liked the fact that there is a way for them to get the credit. And the immediate feedback was a gratification that many of us don't get, the instant feedback, instant gratification that you got the credit for your work.
I think that's amazing, because if I were someone that was out on the floor using that equipment, I would really appreciate seeing that my colleague had cleaned that equipment prior to, change of shift or what have you. Because I think, oftentimes there is that without that visual indication, there is that, oh, geez, how long ago was this cleaned? I don't know. I'm not sure. And then, there's that uncertainty there. And I, again, appreciate the fact that it then, made it easier for staff to know when they should be cleaning and disinfecting again.
Yeah, because plus there's that hectic first hour to 2 hours of a shift where you're running around trying to get meds, trying to get report, trying to assess. And it's a quick look to see that that's one task you don't have to do is the cleaning, running around wiping your environment. So Jesse, I agree with you.
Yeah, anything you can do to make their lives easier.
Mm-hmm.
One more, in the same log that we can use for during accreditation visits, the same log, you can pull out daily reports. And if there are equipments that have not been cleaned, many hospitals have dedicated cleaning crew, and you can hand those out and they can track them down, either visually looking at the screen or through the EE numbers or equipment numbers, and make sure there's 100% compliance. So it's another feedback they gave us that we didn't think of is pulling a list that is deficient, because you can color code, red for not cleaned yet or something like that. So that's another feedback the nurses gave us during our focus group.
And do correct me if I'm wrong, but the article mentions that it is programmable. So if you were to give EVS or a cleaning crew or whoever this list, and it was an equipment that needed a different dwell time than another piece of equipment, is there instruction for them to know that when they go to clean the item?
That is, it is programmable, because everything we want to say is in essentially a microchip. You can display whatever you want. It is pretty similar to when you go to Sears or to Macy's and you want to look at a price, a click of a button can put them on sale. You don't have to go put individual labels. So you can have the display that this equipment needs, 3 minutes. And then once you do it, you get the credit that it was cleaned 6 hours ago or 4 hours ago. And when it is time to clean again, you can change the display status. Instead of saying 12 hours since disinfected, you can change it to dirty or needs 3 minutes of contact time. So that display is interchangeable.
Okay. That's good that there's a little bit of instruction for somebody who might not be as familiar with the dwell times in the equipment. Because, radiology equipment sometimes requires a little bit of a longer dwell time or whatever, et cetera. Well, Dr. Jinadatha, I think this is fabulous work. I think this could just revolutionize our jobs, make it so much easier. So thank you so much for dedicating time for doing this.
Absolutely. And that this, as a researcher, as a clinician, and as an inventor, I've always hoped and thought that something I think of can help others. And I hope people get to use it, adapt it, help improve it, because I will have no more greater satisfaction than that if one more life is saved because of this. That would be the best achievement of my life.
Absolutely.
Oh, that's amazing. Thank you.
So if there's one last takeaway that you would give to the audience, well, first of all, what's next for this piece of equipment?
Well, I don't, I'm not a commercial person, but at the same time, I am hoping that this would be available for other people to adapt. I'm unfortunately not in charge of it, or fortunately not in charge of it. And so a company has licensed it from the VA, and the hope is that they will bring this to life so other interested institutions can use it and hopefully contribute to improve it to where it becomes a standard of care. And that would be my hope and wish, because I think that can make a difference in our veterans' lives and our patients' lives. What's next is that this was the beta version. If there are additional feedback from end users, such as the ones that our focus group gave, and I'm pretty sure there are more smarter people around the world than me that can take this and improve this, that would be the beta becoming the next version. And there are other additional features. One of the additional features is it has real-time location capacity that can be done. So it can even change based on, for example, if you have a isolation room, if it goes into the isolation room and comes out of the isolation room, it can beep to alert the end user. So we have some additional things. The possibilities are endless. We wanted to have something of a minimal viable product that can start doing a difference immediately. But there is obviously room for much improvement.
This is amazing. And I like the idea of using it in other areas as well, outside of healthcare, like you mentioned, bathrooms in public spaces and things like that. I think you're right. There's so many different possibilities and so many different uses. It's just phenomenal. Thank you so much for sharing with us today.
Absolutely. It's been my pleasure.
Yep. Yeah, it was great to have you on. It was wonderful to meet you, Dr. Chetan Chinadatta. We are very appreciative that you've come on the show today, and we thank you again for sharing all the hard work you've done. We are Nikki Shore and Jesse Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business. To hear other AJIC podcast episodes and to access information about this podcast in the field of infection prevention and control, go to our website at agicscienceintopractice.org. That's AGIC scienceintopractice.org.
AJIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Research Committee and Pat Stone and Jean Brandt at AJIC and APIC staff, Lisa Tomlinson, Liz Garman, Bobby Gulshan, Chris Ruiz, Kelly Lynn Russell, Sylvia Quevedo, Kaylee Deaton, and Christine Miller. We work in partnership with Human Factor and audio tech Blake Alton.